Welcome everyone. Today we will learn about Ventricular Septal Defect or VSD. VSD. There is only 4 common types of VSD. Muscular VSD. There is a variant of muscular VSD known as Swiss cheese VSD. Then there is Membranous VSD. Okay. Then there is a type of VSD known as Outlet VSD, also known as supracrystal VSD. It is from the crista magna, so it is known as supracrystal VSD. Okay. And the fourth one is known as inlet VSD. It is very rare and not present alone. It will be associated with various type of syndromes. So we will discuss mainly these three. Okay. Now what is the pathophysiology behind VSD? Pathophysiology. I will use different color here. Like it is your heart. You know the name of the chambers, I will not bother here. It is the pulmonary artery, it is the aorta, and in VSD there is a gap in the interventricular septum. So here is a gap. Okay. Okay. It is a gap in VSD. So how will the blood flow? Blood will flow. It is normal supply of right side of heart, and here is the supply of the left side, and then there will be shunt from left to right side, from left ventricle to right ventricle. There is a catch. I will discuss it later on, but for now you know from blood will flow from left ventricle to right ventricle. So there is a more blood supply in the right side of heart, so the pulmonary artery will carry more blood and there will be more blood to lungs. So there will be pulmonary plethora in chest X-ray. I will discuss it later on. Okay, but when we do ECG or echo, we will find a strange thing that there is left axis deviation or left atrial hypertrophy or left ventricular hypertrophy. You may be surprised why it is happening. The blood is coming from left side to right side, so there must be an enlargement of the right side of heart, but that doesn't happen. Usually what happens? The blood will directly go from left ventricle to pulmonary artery, bypassing the right ventricle. It is a 2D diagram. When I will discuss with you with a 3D diagram, it will be more clear to you. Okay. Now, so from left ventricle, blood is directly going to pulmonary artery, then to lungs, then to pulmonary veins, to left atria, then left ventricle. So there is more blood flowing towards the left heart, so there will be left axis deviation. Okay, due to left atrial hypertrophy or left ventricular hypertrophy. Okay, there is a murmur heard as there is a shunt of blood, but to produce a murmur, the pressure difference between two chambers should be more than 12 mm of mercury. In case of VSD, in systole, the pressure difference is more than 12, but in case of diastole, the blood supply is less than 12. Sorry, the pressure difference. So the murmur will be heard in systole, okay, not in diastole. So the murmur will be known as pansystolic or holosystolic murmur, also known as Rogers murmur. Okay, now clinical features. How the patient will present to you? There will be respiratory distress, there will be cough as there is pulmonary congestion, there may or may not be fever. Okay, there will be, in case of newborn babies or infants, there will be suck cycle. There will be diaphoresis or forehead sweating due to excessive adrenergic activity. Okay. Now these are the clinical features. What will be the signs? These are the many symptoms. What will be the signs? When you put your stethoscope here, mainly in the left parasternal region, there will be a murmur heard. The murmur will be heard throughout the heart, throughout the precordium, but mainly heard in the left parasternal region. Okay, there will be hollow systolic murmur. I have discussed it early. Murmur. There will be wide variable split of second heart sound. Okay, these are the main signs. Now, what will be the finding in the investigation? In chest X-ray, you will find there may be cardiomegaly. There will be pulmonary plethora. On ECG, we will found what? Left atrial hypertrophy, left ventricular hypertrophy, and left axis deviation. In echo, we will find left atrial hypertrophy, left ventricular hypertrophy, and we will find the VSD. We can find the jet of blood flow by Doppler. Okay, by Doppler. Now, what is the treatment? Treatment is mainly there will be congestive cardiac failure. So you will give diuretics like Lasix. You will give them ACE inhibitor like enalapril or enam or ARBs. You can give. Okay. You have to give infective endocarditis prophylaxis, as it may be a complication of this disease. Okay. But the definitive management is surgery. Definitive management is surgery. In most of your muscular VSD, except for which is variant, muscular VSD closes spontaneously. But membranous VSD rarely closes. You have to do surgery. In case of supracrystal VSD or outlet VSD, supracrystal or outlet VSD, you have to do surgery. If there is failure of medical management like diuretics, ACE inhibitor, but that is defect, or there is CCF like findings, failure of medical management. Okay. And lastly, QP-QS ratio is P means pulmonary and S means systemic. Blood flow difference is more than 2:1. Then you have to do surgery. Okay. Surgery is what? You will put a patch. Here is the defect. You will put a patch here, and it seems to be very easy, but not so much easy procedure. Okay. This is a overview of VSD. For more information, you have to read Nelson. Thank you.